Okay, so this project has been going on for a very long time. I can tell you exactly when it started. I was attending a conference on cancer in one of the European meetings in 1993. And out in the lobby outside the lecture hall, I saw a poster being presented by Romano Demichelli. And this caught my attention. It showed a bimodal relapse pattern in patients from Milan. This was quite interesting to me. This was a large database, 1,173 early stage breast cancer patients. This is, of course, before the use of chemotherapy, so this is mastectomy only. There was a sharp peak in relapse hazard. I'll show you that in the next couple slides. Sharp peak at about 18 months, a minimum at about 50 months, and then it started up again with a broad, shallow peak that has a maximum at 50, 60, 70 months with a long tail extending to 15 and more years. This general pattern has now been identified in over 21 databases from US, Europe, and Asia. Next slide. Okay, these are the data from Milan for the postmenopausal patients. This is shown in hazard of relapse. Hazard of relapse is broken up by windows of 3 months. So for every 3-month period here, a patient who enters that window without having relapse and undergoes a relapse during that 3-month period, this is what is given as a relapse hazard event. So what we see here is that there is well, first of all, the data were presented by Romano Demichelli, a good friend and colleague of mine from Milan. There is a very sharp relapse hazard at about 30, I can't quite see it on this thing. It's about 18 months. There's a sharp peak in relapse for the postmenopausal patients, minimum at about 48 months. And then that second peak, shallow peak at about 60 months. And then it goes down to, as the time goes on to 10 years, you can see some activity at about 100 months. We don't know what that is. It could be noise or it could be important. Okay, that was the postmenopausal patients. And then the next slide shows the premenopausal patients. It's similar to the postmenopausal, except that that first peak at 18 months now seems to show up as a peak at about 10 months and another one at about 30 months. And then you still see that 50-month peak and then going down to 100 and more months. Next slide. This is slide number 6. Okay, these are data that was published by Bonadonna and Valagusa in the New England Journal in 1995. What you see here is the probability of relapse-free survival. It starts off at 100% at time 0 by definition. There's a very rapid fall off until about 5 years, where it seems to reach a very flat plateau, and then it starts dropping off again from 5 years out to 15, 20 years. That shows that suggests that there are 2 groups of relapses, and one of them, the first one that relapses within the 5-year period, actually most of the activity is over and done with at about 3 years. That's a period where there are rapid relapses, and then it seems to terminate at 5 years, and then it continues on a much slower decay down to 15, 20 years. Next slide. This is now slide 7. This was a figure from Bernie Fisher. Fisher died at age 100, maybe 5 years ago. He was a very distinguished researcher in the world of breast cancer. He was the first person to propose that breast conserving surgery can be done. In this figure, Fisher reports the relapse rate, the relapse-free survival for patients treated only with surgery, and they're grouped by nodal count. The curve on top is for nodes of 0, and the curve on the bottom is for nodes greater than 12. As is well known to everyone in this group, nodes positive is the most important prognostic factor for relapse in breast cancer. What you can see here is on that top curve, just simply removing the primary tumor will cure 80% of the patients. They don't need any therapy. But of the 20% that relapse, about 10% of them relapse in that first 3-year period. And then there's a flat area with very little activity. And then after 60, 70 months, it starts to drop again and flattens out at about 10 years, 12 years. The curve on the bottom is for nodes greater than 12. And just looking at it grossly, the same things happen to the 12 and more nodes patients, more than 12 node patients, and the 0 node population, but the magnitude of the effect is far different. The relapses in the first 3 years for the more than 12 nodes positive is about 85%, and then there's a flat period until about 72 months where it drops again, and it's essentially 0 from 100 months on. Something is going on here. This is telling the story. Let's continue on. Okay, the next slide is figure 8. This general behavior, these data are not explainable with the continuous growth model that has guided early detection and therapy for breast cancer in many years. Next slide, please. This is slide number 9. Dema Kelly and I decided to collaborate. We have different backgrounds, so some overlap. My background is I have a PhD in experimental physics, and I made a career change in 1982 into cancer research. My expertise is, among other things, I'm pretty efficient at the use of computer simulation to study tumor growth. So what we describe in this triangle is that we are trying to understand the relapse patterns, that 30-month peak, the 10-month peak, the 30-month peak, and the later peaks. So the theory here, the activity here is we're going to take the Milan database, Panuccia, Valagusa, and Johnny Bonadonna, and take the growth model from Dema Kelly. Dema Kelly is an MD PhD. He did a lot of work in studying tumor growth in animals. And he said that the most general pattern for tumor growth is that a cancer cell starts off as a single cell, and it can remain dormant for a variable period of time. And then all of a sudden it grows to about 1 millimeter where it seems it can't stop there, waiting for angiogenesis to kick in. Once angiogenesis occurs, it can grow to a detectable size tumor and a lethal size tumor. So my activity in this project was to take tumor growth model from Dema Kelly and the Milan database from Valagusa and Bonadonna and try and understand what those various peaks mean. Papers were published by a number of us. I published several papers on early activity here, Breast Cancer Research and Treatment, 1997 and 2001. And Dema Kelly published a paper in 1997. These were companion papers. We met for a week or longer in Colorado Springs. I was a professor at the University of Colorado at that time. So we ended up with this idea. And so looking at these data, I can tell you what the results of the computer simulation was. Okay, this is now figure number 10. This shows the computer simulation results for the superimposed upon the premenopausal patients. So you can see the 10-month peak and the 30-month peak and that 60-month peak. The peak at 10 months corresponds to surgery-induced angiogenesis. These are micrometastases sitting in a dormant state, awaiting angiogenesis at the time of surgery, and something happens at or about the time of surgery to induce angiogenesis, and they show as relapses at about 10 months, a very sharp peak. The 30-month peak are surgery-induced activity of single dormant cancer cells, and they ended up going through single growth until they get to an avascular micrometastasis, and then they get angiogenesis stochastically, and they show up as relapses at about 30 months. The late relapses, 50-60 months, are pretty much unchanged with the single cell activity and all that. But there's something it's not the late relapses past 50 months are not particularly synchronized to the primary surgery. Next slide, this is slide number 11. At this point, I'm going backwards in time. This was in 1989. I was visiting professor at the University of Texas, San Antonio. I had a 6-month project that was initiated by Bill McGuire. McGuire was the person who first reported that hormones, estrogen and progesterone, are prognostic factors in breast cancer. This, of course, led to a number of therapies for that. Okay, so this I was doing. I had a 6-month appointment, and the thing was I had to tell McGuire that at 4 months, project failed. I looked for everything. I couldn't find any problem except that the project failed, and I had to admit to him that it failed. So McGuire called in the person who designed this clinical database, and took him about 10 minutes to say that one of the columns I was given was mislabeled. I was told that these data were relapse data, but that was not the case. They were actually the date of the last visit from the patient to the clinical oncologist. So McGuire says, well, there's not enough time left in the project. You can do whatever you want in the last 2 months. So I spent it doing a literature research in the University of Texas, San Antonio. It was a beautiful library, an elegant place to do this project. This was also at a time when cancer was not treated right away. When a physician is given a patient comes to the physician and has clear activity of cancer, they don't operate right away. Just watch it for a variable period of time, watchful waiting. In this case, this was a 16-year-old boy who was diagnosed with osteosarcoma, and it was published by, I can't quite see the bottom here. Yeah, Smithers in 1968. And I published this copy of a paper from Smithers in a medical hypothesis paper in 1990. So if you want to look that up, it's very interesting. I was looking for data on untreated cancer, particularly breast cancer, And it turns out in that year, 1968, 1990, physicians, as I mentioned, can just watch and wait when they have an active patient with cancer. In this case, this was a osteosarcoma, and the physician, Smithers, was watching the lung to see if he can see any metastases. It's well known that osteosarcoma relapses to the lung, and so Smithers was looking for it, and for about 6 months, he took x-rays, nothing. All of a sudden, at one point, he found some activity at the lung, and then he followed that tumor as it went another year until it got to be 12 cubic centimeters. And he removed the tumor, and it was just ordinary cancer. The spectacularly interesting thing about this figure is that it looks like the first time that the physician, Dr. Smithers, saw the activity was just when they had the, I can't see it. I don't know if you can see it. That's when they amputated the leg. Yeah, okay, I can just barely see it here. That, when they just visible, that's when the turns out that they can see the tumor there. That's also when they had the amputation. I don't know if you can see it in your file. I can barely see it in my image here. But something was going on here. I am a physicist, and I'm interested. I'm really good at analyzing graphical data. I don't like to see just some statistician say it's significant or not. I want to see actual data. And this was very intriguing. What's going on at that point when they just found the visible lung metastasis? Was that a coincidence that the surgery to remove the leg, when they amputated the leg, was that a coincidence that the removal of the leg? It was exactly when.
Moi, j'ai fini la dernière fois le gâteau au chocolat.
I can't, someone talking? Someone asking a question? Someone, can you hear me?
Yes, Doc, we can
Yeah,
hear
I'm not,
you. Yeah.
you have not heard me before this? Is that what
No,
you're
no,
telling
no,
me?
no, not like that. It just got muted now. I think it's fine. We
Okay.
heard your
So,
presentation.
all right, thanks. So the question I was asking, what's going on here at that point when they had the amputation and just when he first saw that visible metastases to the lung? Was that a coincidence? It seems to be a very scarily remote chance that could be a coincidence. If it's not a coincidence, is it possible that the amputation caused the relapse to the lung? And if that happens, how often does it happen? Does it happen 1 out of 100 times or 99 times out of 100? You can't tell from this figure. This figure shows good evidence that at least in one case, removal of the primary tumor by amputation coincidentally happened when they first saw the metastasis in the lung. Okay, so that's it. This is very interesting. It strongly suggests that surgery can cause a relapse. Doesn't say how often, but surgery can cause a relapse. So let me go on to the next figure. Okay, Demicali and I were very interested in this, and we each did independent studies on what's going on here with that relapse. Does surgery cause relapse or does it not? So we published papers in 1997. We met in Colorado Springs, spent some time there, and then we had a driving tour with Demicali and Panuccia Valagusa. Went to to the Indian country, that's the American Indian country, and spent some time there. Very interesting trip, and I got to know Panuccia Valagusa and Romano Demicheli quite well. It was a very useful trip. So Demicheli and I each published papers. There's a Retsky Demicheli et al. Paper and a Demicheli Retsky et al. Paper. My paper, Retsky Demicheli et al., I used computer simulation to study these data to try and understand what happens with that early relapse, that surgery, potentially surgically induced relapse. And I came to the conclusion that the relapse peak at about 50 to 60 months can be explained by a steadily stochastic progression from one phase to the next phase. However, if I wanted to account for that first relapse peak, the one at 30 months, it turns out that a sudden perturbation of the development at the time of surgery is necessary. Demicheli was using a different method. He was examining clinical data, looking for examples of such things in breast cancer metastatic development. And my conclusion was that the second relapse can be explained by a steady stochastic progression from one phase to the next phase. However, to account for the first relapse peak, a sudden perturbation of the development at the time of surgery is necessary. And Demicheli wrote something similar. The conclusion was similar, but the whole method of analysis was different. Demicheli wrote that primary tumor removal was revealed as a potentially perturbing factor for metastases development. So we came to the same conclusion from totally different viewpoints. Okay, the next slide. This shows the result. This is slide number 13. This shows the quantitative result of the computer simulation. Those first peaks at 10 months and 30 months, they're composed of two previously unreported surgery-induced relapse mode. The 10-month peak were dormant avascular micromets that were induced into vascularized and showed up as 10 months. And this is pretty much limited to premenopausal node-positive patients, in which case 20% of premenopausal node-positive patients undergo this relapse mode. And it's 5-to-1 node-positive to node-negative and 2-to-1 premenopausal to postmenopausal. And the numerical result here is that 50 to 80% of relapses are iatrogenic. They are generated by some intervention, and they present at 10 and 30-month peaks. And the peaks increase with tumor size and nodes positive. And the late events, 50 to 200 months, are mainly the result of cosmetic or health-related surgeries. If a patient wants to have a reconstruction, they can certainly do that, but within a number of months, 20, 30 months after the surgery, there is a relapse. And it looks very much to us with the computer simulation that it's the result of cosmetic surgery or health-related surgeries, those late events. Okay, going on to the next slide. So this is slide number 14. I've looked at a lot of cancers, and I can see, I have a very trained eye. I've been looking at these data, these relapse data for years. And I can tell you that every cancer I've looked at, if you know what to look for, you can see either in large databases or in case reports that there is surgery-induced activity. Pancreatic melanoma, lung cancer, on and on. Every cancer I've looked at has that. Okay, next figure. I need to enlarge this. Can't see. Okay, now I can see it better. Okay, conclusion. Well, just looking at the quantitative clinical observations in breast cancer. I'm gonna, well, the adjuvant, first, there are four mechanisms that could be explained by what I just proposed in the past few slides. That first paper, there was an adjuvant chemotherapy works particularly well for premenopausal node-positive patients. Published a paper in 2004. I was first author, and Bonadonna was second author. Bonadonna was the director of the Milan Cancer Institute, and he's dead now, but he was very influential in learning how to treat with chemotherapy. He was the first person to use multiple drugs to treat breast cancer after surgery. And Judah Folkman is there. I was on Judah Folkman's staff at Harvard Medical School at the time. Folkman, Folkman had spent 30 years studying angiogenesis, and Bonadonna had spent 30 years studying how to treat patients with chemotherapy. And everything makes sense to them. It looks like the surgery-induced activity seems to be explainable by their Bonadonna's reaction that surgery seems to cause excessive and rapid tumor growth right post-surgery, and that's when Bonadonna found that chemotherapy is most effective. And Folkman looked at this and said, this looks like surgery causes angiogenesis. Bill Retsky, this is another little interesting wrinkle. About, let's see, in 1996 or 1997, I was diagnosed with stage 3C colon cancer, and Bill Retsky was my medical oncologist. I was treated with, instead of maximum tolerated chemotherapy, which I thought was hopelessly flawed, I opted for a low dose long-term therapy that is now called metronomic chemotherapy. So Retsky designed a protocol for me, and I underwent it. It was an easy protocol. I took low dose 5-FU every night. I went to bed for about 5 hours, and I had that 5-FU for 2.5 years every night when I went to bed. And Panuccia Valagusa was the database manager, and she was also a co-author of this paper. The second one is also very interesting. It turns out that mammography works better for women premenopausal than women, it works better for women postmenopausal than premenopausal. I was on Folkman's staff at the time, and Folkman had Friday morning meetings, and Folkman had a very rare guest. He didn't like reporters in any event, but he happened to be told about this Amy Marcus, who was a Pulitzer Prize winner from the Wall Street Journal. And for a few meetings, Amy Marcus was at the meeting, and a coincidental correspondence, just a discussion with Amy Marcus and myself. She asked me what I'm working on. And I told her, I said, we are studying the effect of surgery causing relapse, and that could explain why mammography works better for women postmenopausal than premenopausal. And Amy Marcus got very interested in that, and she wrote a report in the Wall Street Journal. I think it was September 25th of 2005. It was published on the front page of one of the major sections of the Wall Street Journal, and Harvard issued a press release at that same time. So that got a lot of attention. The one thing that happened that was really interesting, we got a letter to the editor from Isaac Gukas. Isaac Gukas, who died of cancer in the past few years, he was a native of Nigeria, and he was a surgeon he ended up moving to UK, where he was doing surgery at UK. And he said this could explain what we found in this paper. It could explain why women in Nigeria don't go to see a surgeon when they feel a breast lump. Instead, they go to an herbalist where they get some soothing ointments, and then they go back to their village where they die of untreated breast cancer, but relatively comfortable. This whole thing got a lot of attention. I ended up working with Isaac Kukas on this project. We published a number of papers, and I won't spend any more time on this, but it looks like this could explain what's going on, that surgery causes relapse. And what Isaac Kukas discussed, what he talked about was that the surgery provoked relapse. Okay, the next slide, this is number 16. Apparently something happens at or around the time of surgery to precipitate these early relapses that account for over half of all breast cancer relapses. And surgery apparently caused something that induces angiogenesis of dormant avascular micromets and starts growth from single dormant cancer cells. And this may be a general effect. It might show up on all the cancers. Skipping ahead to June 2010, a paper was published by Patrice Forget. Patrice, that's a male name, by the way. Patricia would be the female name. He is French. This was in Brussels. He was a anesthesiologist working in Brussels. And this is a teaching hospital, so they had to expose the residents and anesthesiology to all the drugs that are used in anesthesiology. So they decided to do a retrospective study where they grouped all the patients who were treated by one surgeon. I think there's something like 350 patients. And what Forget and his colleagues did, they did an analysis of the relapses of those patients and grouped them by what drug was given as anesthesia. And it turns out that ketorolac and NSAID had far superior relapses compared to every other drug that was used. There are 3 NSAIDs that can be given as IV, but at this time, the only NSAID that they had in Brussels was ketorolac. Turns out that
Hello,
ketorolac.
Dr. Michael.
Yes.
Yeah, I'm so sorry for interruption. We are running out of time. Can you please conclude your presentation?
Okay, I will skip on here. We ended up coming to the conclusion that the majority of relapses consist of surgery, angiogenesis, and single cell activation, triggered by primary surgery that causes systemic inflammation, lasts about a week. And let me go on. The relapses are 5-fold reduced. There were 2 clinical reports presented in the last couple of months. One paper by Bodway. I was invited to speak at a conference in Mumbai, India, in 2016. I gave a 20-minute report, and then I didn't hear anything more until a few months ago, perhaps. Bodway reported that they did a clinical trial of 1,600 patients, and they used local anesthetic lidocaine at 0.5%. It was given to half the patients 5 to 10 minutes before the surgery. And the result of this 6-year clinical trial was that this is a easily implementable intervention that can reduce 1 out of 4 recurrences and 3 of 10 deaths in women with early breast cancer. No adverse effects due to lidocaine injection. This document has been passed around the world. Lung cancer patient, there was a study done by MD Anderson where they looked at patients retrospectively who had been taking NSAIDs at least once per week and compared those to the patients who had not taken NSAIDs. There were a total of 30,000 subjects, and the result, there was a 5-year survival advantage for the NSAID users compared to the non-users of 30% to 15%, 13%. Okay, that's pretty much it. One tough question is, surgery apparently initiates metastases in breast cancer and other cancers. Is that good news or bad news? And I think it's good news because it leads to a simple way of preventing relapses if you can control inflammation. And other organizations might think it's bad news since women who hear about this are less likely to get mammography. Okay, that's it. Thank you very much. So here are my co-authors, Romano Demichelli here, Bill Retsky, who was my medical oncologist, his wife, Pat Wood, who died of cancer. She was also a medical oncologist, Rick Rogers. I'm standing in the background up top here, Pinuccia Valagusa and Gianna Bonadonna. Upper right, Patrice Forget. Vikas Sukatni is down in the lower, in the first upper right there. And Osaro Erhabor, I've been to Nigeria 3 times. Lower right, Judah Folkman. And here in this picture in the bottom, I am there, Isaac Gukas and Michael Baum, a retired surgeon. And at this time, Isaac talked about a time in Nigeria when he had a televised debate with an herbalist on how to best treat breast cancer. And lower left is Ted James. Okay, that's it. Thank you very much. I'd be very happy to take any questions.